In the last 8 years, we continued to use ISQ in many more applications, and one of them for 3.5 years now is for the immediate implant placement and implant restoration cases. And you see, when you look at the two types of implant sites today, we differentiate between post-extraction sites and healed sites. And now when we talk about immediate implants, of course, we go into the area of post-extraction sites. And we have a very clear selection criteria when we can use immediate implants. Today, ITI is using this nomenclature and has served us extremely well. This is based on 4 consensus conferences, and you see that immediate placement, of course, has been established in the late 70s. Late placement was what P.I. Bronnemark and André Schroeder did, and in between we used the term early placement with soft tissue healing or early placement with partial bone healing. So when you extract a tooth, you should know what you do, and therefore you have 3 options at the day of extraction. Either you go for immediate implant placement, or you go for extraction and spontaneous healing, and the aim is then early implant placement after 4, 6, or 8 weeks, or you go for extraction and socket grafting, and then you place the implant at 4 months. And with immediate placement, of course, we are concentrating now on the first option. We don't use it often. That's less than 10% in aesthetic zone, about 5-6%. We use it only in thick wall phenotypes. So that means the buccal wall is fully intact and it's more than 1 millimeter in thickness. No acute infection should be present. And you see here a thick facial wall, implant placement following extraction, and an internal grafting. No flap elevation. You have to use computer-assisted implant surgery to maximize the correct implant positioning. You have to use a full digital workflow, and we use that since 3.5 years now. And you see a diagnostics is done with a cone beam CT and, of course, an intraoral scan. You have then a DICOM file, an STL file to do the matching, then the planning, export, then the planning for a surgical guide, and then you use a 3D printing for the surgery, and so on and so on. And you see here one case we did in 2017. You see a thick wall phenotype. The tooth has been very carefully extracted, and then the socket explored. Yes, everything is as expected. Then we prepare the implant bed through the surgical guide. We insert the implant, and we measure ISQ 76. Then we put a healing cap on and do an internal grafting. And when the grafting is done, the provisional crown is actually providing the primary wound closure because it's sealing off the soft tissue wound. Here you see the patient at a 1-year follow-up. This bone level implant is very well integrated. The buccal bone situation, the buccal ridge anatomy looks very promising. Here you see the 2.5-year follow-up, and the patient allowed me to take another cone beam, and you see the buccal bone wall is fully intact. So a very pleasing case. Then a more recent patient we did in 2019. We have further improved the technology. Now actually we produced already the provision crown with CADCAM technology. You see very favorable anatomy. The facial wall is thick. Now we are using the so-called BLT implant of Straumann because this further optimizes the primary stability of the implant. The planning is done. Then the matching is done, the position is selected. It's always a compromise between the prosthetic needs and the anatomic needs. Then I agree here with Dr. Samir Abu Ayyash on the correct positioning. The surgical stand is produced, and then we do the surgery. So we extract the tooth very carefully, and then we prepare the implant bed, put the BLT implant in, and measure ISQ 81. Very typical, high value. And then we do the grafting, and then the pre-prepared implant crown is adjusted, clearly out of occlusion, no contact to neighboring teeth at the contact zone, and the patient leaves the clinic with a provisional in place. And now, of course, the soft tissue healing is done beautifully around the emergence profile of this crown. Here you see the patient at 3 months, perfect healing. See, Samur Abu Ayyash, a top orthodontist in our dental school. And then we went into final restoration. Here you see the lady I saw the last time in last November. Due to Corona, I didn't have a chance to see her again. We will do that now. And you see an excellent outcome with this. So I'm very pleased, gives me a chance. We did about 25 patients. In 2 patients, ISQ was not 70, and then we could not restore the case with a provisional crown. So that helped us extremely.